Olá a todos, então bem-vindos a mais um podcast. Estivemos aqui ausente umas semanas por motivos profissionais. O título deste podcast é a influência da articulação temporomandibular na postura e na deglutição. Portanto, vamos falar com o Stefano Colasanto. Colasanto é dentista, é osteopata, já há mais de 20 anos e 30 anos que exerce a profissão de dentista e há mais de 20 anos a profissão de osteopata. É docente no ensino superior, foi professor em 3 mestrados, se não me engano, mestrados em neurofisiologia e patologia de postura estática e dinâmica, mestrado em terapia miofuncional e postural, mestrado na área da dentária, da medicina dentária, é um membro da Sociedade de Ortodôncia desde 1995, é um osteopata registado e estuda desde há umas décadas principalmente as correlações entre as disfunções temporomandibulares, a maloclusão, a deglutição e a postura pelo meio de uma abordagem, uma intervenção osteopática e também com os seus conhecimentos na área da medicina dentária. O podcast vai ser em inglês e pronto, eu vou então avançar para inglês. Stefano, thank you so much for accepting my invitation. It's a pleasure. I've been following you on the social media for a while. I think we talked the first time we talked, I think was like 5-6 years ago.
Yeah, maybe.
So thank you so much for accepting my
thank you for your invitation.
And yeah, we've been talking off record. We were talking, there's so many misdiagnoses when it comes to pain, facial pain, when it comes to headaches. It's so complex, and the recent studies have been and papers have been kind of, putting it out there so that to review, especially the societies like the International Headache Society and stuff like this, to review the clinical guidelines, because 10-20 years ago everything was about the central nervous system, but there's discovering so many things between the neuromeninges, the postural muscles, the connection with the trigeminal nerve and how it behaves in terms of proprioception and inflammation, the correlations between eye movements, jaws, neck, posture, all that neurodynamic physiology and function. I mean, we could go. It's even hard to pick a subject because we could go so many different ways. But basically, it's still an area, this TMJ dysfunction and this posture, it's still an area of debate. If we talk to certain individuals, they have a kind of one opinion or one register, one way of seeing, maybe they learn in a certain way. If we talk to other individuals, I remember like 10 years ago or maybe 6-7 years ago, this idea of the tongue and the TMJ and the posture was so, in certain spheres of academia, they would make fun. They would not take serious any of those things. So anyways, there is like I would say like one branch of this, the people who work on this type of field, which manual therapy is not important. What is important is active exercise. That's what the evidence shows. Manual therapy is as effective as exercise or less, and but in clinical work we actually see in the clinic this importance of actually mobilizing in a passive way, also active way, the tissues. We know what were the effects of manual therapy. So anyways, I don't want to take too long to ask the first question. Usually I take a long time to ask the first question, but I'm going to go straight to the question. You've been working on this field for 30 years, 25 years as an osteopath, talking about evidence of manual therapy, clinical evidence, scientific evidence. Where do you stand? How important it is manual therapy for temporal mandibular dysfunction in specific, and exercise and stuff like that?
Well, thank you for your question. First of all, I would like to point out that perhaps more than a misdiagnosis, it would be more correct to talk about partial diagnosis. I mean, our point of view as dentists, as medical doctors, is that TMJ is a joint apart. Actually, it is true that TMJ is a completely different joint from other joints. We consider TMJ as the most free joint in our body. In osteopathy, we know that freedom is equal to adaptability. So the TMJ is the most adaptable joint in our body, and that's the problem, because if we observe, if we look at our body, our joints, from our feet, from our head, we have all the backbone with the sacroiliac joint. It is very tough joint. Then lumbar joints, lumbar vertebrae with 5 degrees of rotation, so very little mobility. Then the great field or dorsal vertebra with 8 joints for any vertebra, for each vertebra. Then the cervical vertebra, very mobility, very mobile, very free. And after all the 6 lower vertebra, we have even a vertebra without a body. So it is the most absurd vertebra bone in our body. And then it is not at the end, because the very end of our mobility is the top of our joints, and the top of our joints is TMJ. So TMJ, it is not just for this reason, but it is on the top of the iceberg of our posture, of our backbone. And that's true that we have not 2 joints, but we have 2 joints for each side. And as Rogabato teaches, so Rogabato is one of wonderful physiotherapists from Santiago in Chile, and he spent his own life, his whole life on TMJ from manual therapy point of view. And we have 2 joints. The lower joint is the typical TMJ as we are used to see. So we have the condyle and the disc, and it is pertinent. It is for dentists, it is for neonatologists, it is for whoever. But we have also an upper chamber, an upper space, and a second different joint from the disc to the temporal bone, to the skull. And all this second upper joint is for osteopath. It is for manual therapists, because from that point behind, so the skull, C0, C1, C2, and so on, it is for manual therapy. It is for osteopaths. It is for kinesis. And that's the trouble. And it is not possible to understand TMJ if we don't point out that we have an unicum in our body. All the muscles, chewing muscle, are different from any other muscles. The structures of these muscles are completely different. They have their own laws. They are different from other muscles. Even from the neck, that is quite near to the joint of TMJ. So chewing muscles are different. Joint is different. There are a lot of difference. So that's the trouble. And it's not possible from one point of view to treat TMJ the same way as we used to treat any other joint. But on the other hand, if we see TMJ from the orthopedic point of view, it is a joint. So it is not possible to treat it without manual therapy, because we used to treat any other joint, the knee, the arm, the ankle, the hip, with manual therapy. So it is very important to understand that we face a completely different joint with different laws, but it is a joint. So we have to match our medical point mentality, our manual therapist mentality, our osteopathic mentality, and we have to match them if we want to solve TMJ. That it is not a case, it is not by chance that it is the most studied joint in our body, because it is the most strange, weird joint in our body.
Yeah, and somehow I was just thinking as you were talking that actually it's the third podcast about TMJ, and it's not it's like it comes up, the subject comes up when I'm talking to my students or some colleague or some patients, and it kind of it keeps on appearing, and also this conflictuous kind of opinions. I was very curious if you can elaborate just a little bit on this particular differences of masticatory muscles, and the rest of them. You mentioned like almost like the physics are different, not the physics obviously, but what are those different aspects, if you can just summarize?
Spindles. The spindles, our chewing muscles are the richest muscles of spindles, but they have no Golgi organ, center Golgi. So and how are rich of
really wow, that's amazing. Wow.
Yeah, but all the fibers of the masseter or temporal muscle are quite different. And if you want to know the particularity of this area, if we have 100 spindles in our body, 50 of them are between the first 3 cervical vertebrae. But another 25%, it is in the masseter. And the masseter ends at C3 level. I mean that, I'm so sorry if you, not you, but another, okay, you people don't believe between the connection between occlusion and posture. It is your problem. Because nature solved this problem millions of years ago. Because the 75% of spindles in our body are in this fascia, in this area. And all of us know that spindles are our posture. So the 75% of our posture is here. And that's a fact. It is not dream on opinion.
Just a reminder, just who doesn't who's not as comfortable to
sorry.
Spindles is portanto, spindles é fusos neuromusculares, e os fusos neuromusculares, so I was just translating in Portuguese, and spindles are receptors, which is the end part of a sensitive neuron, kind of we would say receptors, which is nerve endings or axon endings. There are specific, it goes to the intrafusal fiber, so deep in the muscle, and there's different types of spindles. type 1, type 2 different, but they're basically the receptors they sense the stretching of the muscle. So if it's too quick, too fast, or too on the limit, they will send that stimulus to a motor neuron at the same kind of level. It doesn't go cortical way, it just goes and it tells the muscle, basically gives the information to the motor neuron to contract as a protection. And it makes a lot of sense, because posture, if we can't keep our eyes and our head facing horizontal and facing forward, then we kind of look down. So it makes a lot of sense in terms of posture. And I can imagine it's nature intended in a way that it's much better to swallow in kind of a vertical position than kind of swallowing like this. So it makes a lot of sense what you said. I didn't know about this 75, and the Golgi tendon receptors are the opposite. So it's like for the ones who don't remember, they're also receptors, neuron receptors, and endings of an axon, or I wouldn't say ending, but just the distal part of the
tendon.
That they lie on tendons, and they sense not the stretch, but they sense the tension, the strength, and so they have the same protective mechanism. A very easy example is if I'm lifting 50 kilos weight on my biceps, and if I can't hold it anymore, the tendon organ receptor will give that information, again locally, not cortical, and basically would just release the muscle instead of contracting it. And it makes a lot of sense that those organs don't exist on the. I'm sorry if I interrupted you, but
no. It is fundamental to get this point, because this is a central point. In my lessons to my students, I describe the spindles as the rocket man. At the Olympic Games some years ago, there was a flying rocket man with some rockets, and spindles let us go forward, backward, on the right, on the left. So they are a sort of LED lights of our posture. And for me, the best definition of posture is the best compromise in this moment to counteract the force of gravity. I mean, what can I do to stand up? What can I do also to be seated in a proper way? I am programmed by nature to spend 0 to stand up and 0 to be sitting. Okay, if I have to spend more energy, it is a damage for some part of my body. And osteopathy works very well to eliminate these blocks, to eliminate these lacks of availability, lacks of mobility in our body. So to understand, to restore the best mobility, the best compromise, the best working pattern of my body to react, to counteract the force of gravity. So we have the problem in our body is that osteopathy cannot work everywhere, because sometimes it is not a matter of lack of mobility in our joint, in our muscles, in our skeleton. And we have other very precise areas where we have to make an inquiry, to ask if there is a block over there, there is a lock over there. And we have 2 different areas that are eyes and there are mouth. It is mouth, eyes, mouth, and back. We say in our school that it is a sort of postural triad. I mean, a group of three main information we have to integrate in our visit. And it is possible we teach our students to understand all the possibility of these different integration. So mouth in this frame, in this pattern, is 1/3 of our posture. So it is not a son of a lesser god. It is mainly important. It is 1/3 of our posture. And it is unbelievable what it is possible to do if we can free our joint, free our swallowing, free our occlusion. It is unbelievable for me. I am, as I told you, before the recording, it's 33 years that I've been working as a dentist and 25 years as an osteopath. So I saw some patients in my life, but the first skeptical, it's me. The first unbeliever, it's me. And I have to understand that we have a great key to understand our posture and to treat our patient if we can pass through the mouth. The mouth is occlusion, is TMJ, and very, very important, but completely not forgotten, completely unknown, swallowing.
When you talk about swallowing, are we talking about not just the masticatory muscles, but actually the larynx and pharynx muscles, and also the esophagus muscles, the smooth muscle? Are we talking all the way down to the? So there could be. I mean, we could say that there is a relation between postural malocclusion, swallowing, and, for instance, reflux.
Reflux?
Gastric reflux.
Reflux. Yes, because, well, first of all, we have to consider that we have I'm sorry if I am perhaps too schematical, but it is a habit of mine as a teacher. But
you sound like a teacher. That's very good.
So in our lives we have three main very important activities. They are mandatory. They are stereotyped, so it is not possible to avoid them. Without them, there is no life. Breathing, swallowing, and chewing. So what does it mean? It means that if we breathe, swallow, and chew, not eat, chew properly, it is okay. But if you have a problem in one or more of these three activities, it's a great problem because we are obliged to perform them, but it does cost a lot to us. So some part of our body has to pay the bill. And it is possible, for instance, neck pain, vertigos, tinnitus, and bad posture, but in severe cases also fibromyalgia. And what about reflux? The reflux can be an effect of bad swallowing, because if we swallow properly, we perform a vertical pattern of vertical activity, and in our ideal swallowing pattern, we have to along our neck, along our posture, because our good swallowing is with the tongue on the top of our palate and from forward to backward. And we could be a little taller than usual because the tongue performs all these activities. But if we are not allowed to have a very good swallowing, a very good pattern of swallow food, saliva, and so on, and we have to consider that swallowing is happens 2,000 per day. So it is not just a matter of 1 minute. It is 2,000 that we have to do. We must do a movement that is not correct. And mostly this movement is not vertical, but is horizontal. So a lot of our patients used to swallow in this way. 2,000 per day from the 3rd month of intrauterine life. So it is one of the most ancient movement in our life, also in our pre-life. Okay, so it is mandatory. So we have to adapt to this movement. And how is our adaptation to this movement? We move all our posture forward. And if we move forward our posture, as you said before, it is not possible for us to look at the pavement. We have to extend our head because we are obliged to look at the horizon. So in this movement, we perform an extension of our head and a compression, a huge compression of our upper and mostly also lower cervical vertebra. And that's the problem. So we live in this posture, and it is unbelievable. And I can make a diagnosis of not good swallowing pattern from posture of patient. Mm. And it is a very not completely not considerate problem, and is very, very frequent. And we have also to consider that tongue is the most powerful muscle in our body. And can muscles, move, right? Yeah. So it is one of the most powerful because it can move 2 tons per day, 2 tons, 2,000 kilos per day. So it is a very huge problem. And there is no device that can treat this dysfunction of the swallowing. Just gym, myofunctional therapy. It is a therapy. It is a sort of gym for the tongue. It lasts at least 6 months, but it is possible at any age to teach the body to react, to have a good movement. And it is unbelievable to me, firstly, this is unbelievable to look at the effects of this very simple therapy. For headache, vertigo, tinnitus, posture, and so on.
What is it you said? What is it?
Myofunctional. Myo is muscle. Yeah. Myofunctional therapy.
Myofunctional therapy. Okay. Yeah. You taught on that masters, no? There was a masters with that, and which is active exercises, passive exercises, both.
Yes, but it is not doing exercises without any goal or any objective. You have to teach your tongue to behave more correctly and to spend less energy. And that's the key, because our brain is our manager. If we can convince our brain that there is another pattern that is more convenient, what does it mean more convenient? That the brain has to move less muscles, and it is a lot of muscles less in a good swallowing pattern in comparison with a bad swallowing pattern. So we can treat a lot of dysfunction, but we have the warranty that brain does not forget this pattern. It is just when you learn to go by bike, okay? You cannot forget it. Just because, it is not to bike, but the example I do to my students is it is just like when we pass from walking on 4 legs and passing to the stand-up position. It is a very difficult change. All of us did it when we were very, very young, but for us it is not possible to go backward. It is more convenient to stand up. It is not useful to go back to walk on 4 legs.
Yeah, and it's funny you're giving that example, because I was thinking this morning. I mean, our nervous system, not just the nervous system, our organism is trying to be as effective as possible, to spend less energy as possible.
Yeah.
And I was actually this morning I had this experience. I'm learning this instrument. It's an air instrument with I use a lot of blowing, and I got this experience. Wow, if I start using the muscles in a different way with less energy, less strength. So
that's
basically, I just realized if I do more, if I push more in my belly, or if I push more or with my tongue, whatever, I can produce the same sound or even stronger, but without using so much energy. It was funny because it's what I experienced this morning, basically. So we can be more effective, and it's the same thing with the tongue. How old? So there's a lot of osteopaths that actually are specialized and work mainly in pediatrics. How young should we be aware of this type of issues with the swallowing and tongue and TMJ?
Well, one of the key points is the length of the lingual frenulum. The lingual frenulum is fundamental, and it should be. In an ideal world, actually in Italy, we used to check it up to the 50s in the delivery room. That's a fact. Now we are going to repeat these experiences in delivery room, and it is very, very important for the baby, but also for the mother. Because it is very difficult to have a correct pattern of swallowing with a short frenulum, lingual frenulum. And what is more important, the length of lingual frenulum is the most frequent cause, short lingual frenulum, I mean, the most frequent cause of lack of breastfeeding. Because the baby has not the ability to suck milk from her mother, and we know that that's the point. That's the key to have the start of producing milk from by the mother. So if we don't have a proper sucking from the baby, and with a short lingual frenulum, it is not possible. It is very, very difficult to have production of milk from the mother. So that's the first the first time it is possible to look at proper or improper, correct or wrong swallowing pattern. Then from 5-6 years on. Because the trouble is that we must have a sort of cooperation from the patient. Of course, it is not possible to teach gym, muscle activities, exercises to a baby less than 5 years old. In my experience, of course.
Yeah, and what about the bite? The way we bite, and so we still look at this deviation of the way we chew, or the way we bite, I should say. I do, just as a dentist and also as an osteopath, to still use those markers, and also the mouth guard. I don't know the name in English for at night time. You still go there to the or it's mainly with this exercise therapy, myofunctional therapy. What depends?
No, I in my office I built a lot of bites of mouth guard and so on, but mostly I take them off. Because they are not useful. I mean, we have a TMJ problem, a chewing problem, an occlusion problem. It is not fair to treat all of them with a bite, with a mouth guard, with a bite plane. And what kind of bite plane? In literature, in medical literature, in dental literature, we have kilos of bite planes, different bite planes, lower arch or upper arch, and so on. Firstly, we have to check the function. So the most important thing is to check the function, to check if it is possible to the patient to open and close and deviate the jaw properly, and if not, why? Because there are a lot of different causes, and it is not always depending on the joint. It can depend on teeth, it can depend on neck, it can depend on, and a lot of times that's the case, it depends on dorsal vertebrae.
Dorsal.
Also, yes, the dorsal back is the main station of a lot of things, and that's why if we treat thoracic vertebra, we can have a very large effect, and these are the main area to treat for TMJ problem. So it is not the neck.
It is not what?
It is not the neck. The main area to treat for TMJ problems is a little lower.
Okay, now you made me think. I'm trying to. I mean, I guess because of the
in
natural.
My opinion, of course.
Yeah.
In my experience.
Because of the opposite. I guess because of the opposite forces. No, one is going to kyphosis, and we're talking about vertical plane and horizontal lining. Is that so? Basically, it's a contradictory force of what we've been talking about.
Yeah, but you have also to think about how we change our chewing pattern if we are standing, if you are bending, if you are backward, forward, on the left, on the right. We have a very different occlusion depending on our posture. And it is not a dream, it is not a fairy tale, it is a fact. When I, in my courses, in my lessons, in the first 5 minutes, I try the audience to experience this different kind of occlusion in different with different posture. So it must be clear that there is a complete connection between occlusion and posture, and it is achieved, it is put apart in the first 5 minutes. Okay, that's true. From now on, we can go on. So we know that there is a connection and a link between occlusion and posture. It is not possible to deny it.
I'll put some references also on the description of the video on social media. But is there? I forgot to mention earlier. You're also a co-author of a book, right?
Yeah. Orthodontics. Orthodontics.
What's the title of the book?
La nuova ortodonzia.
Yeah, exactly.
New orthodontics.
The new orthodontics. Yeah, you're also the co-author of that, and you're still connected with this myofunctional therapy. Is there a place where people can go and look? Is there a website or?
No, myofunctional therapy. It is not an idea of mine. It was studied. It was created in Florida in the 60s, in Miami by Gardner.
Especially for.
Yes, it was. He was a speech therapist.
Okay.
Yeah, he was a speech therapist.
I remember. Yeah. Okay.
Yeah, and in the 50s, in America, there was a giant of neonatology of TMJ studies, and I had the honor to know him twice. He was Harold Gelb. Harold Gelb was the first in the 50s, not 5 minutes ago. In the 50s, he was the first to understand the connection between occlusion and posture. And he used to treat all patients of him with speech therapists, osteopaths, chiros, physios, and so on. So it was very clear to him that TMJ was the rival point. It was not the starting point of a lot of diseases. So it is important to treat. One thing that I underline once, twice, thrice in my lessons to my students is please treat TMJ as the last joint in your visit. Even if your patient has a lot of pain in that area, treat as the last joint. That's my suggestion.
Very interesting, and the yeah, I'll put the links because I think this is good. Both the myofunctional therapy and also the also your book or the co-author of this book. So, yeah. but this was like 2001, right? 2002, if
it was 2007, 15 years ago.
Okay. And
I was young.
And you were talking about the same issues.
Yeah. Well, in my office, it is made by speech therapists.
In your profession, you encounter still a lot of struggle with this, a lot of counter opinions and more acceptance now. Or?
Well, there is a very funny mainstream in Italy and also in other countries that for an osteopath is absurd, but I have to report it. According to some guidelines, there is no connection, not between occlusion and posture, okay, but between teeth and TMJ. So it is just like if you say that there is no connection between your knee and your hip, your ankle and your knee. So, okay, if you want to believe it, okay, it's your problem, but nature behaves in another way.
Yeah, and it's funny, we're talking about this we're going to wrap up because we've been here for almost 50 minutes. I promised you would take more than 40 minutes. I don't want to take too much. It's already 10 o'clock your time, but we're going to wrap up by saying this. We're talking about this and off record also. It's funny, this guidelines, because I remember the nice guidelines, the late nice guidelines for low back pain and low back pain. They include also lumbar radiculopathy, and based on their own conclusions of some studies, they concluded that everything was contraindicated for lumbar pain and lumbar radiculopathy. By everything, I mean everything.
But drugs.
From acupuncture to manual therapy to exercise to not exercise, but to a lot of modalities, TENS, electrotherapy. A lot of the only thing they would advise, the guidelines was NSAIDs and anti-inflammatory, non-steroidal anti-inflammatory, which we know they're completely ineffective for a radicular pain, for instance, or like a normal anti-inflammatory. So, anyways, it's funny how science goes sometimes, or in the way we could actually. I was doing a course for 3 days about this type of things, and then it's funny how. It's funny how they put on the same kind of bowl studies that the studies in humans, but they were like with studies that were doing throughout a week only, and then they put together studies for only short-term results, and then they put other studies like long-term results but no short-term, and they put together several therapies in the mixed, but not really a concrete situation. Like for instance, it was very clear in this case that it was a big mess, a big confusion, not a distinction of the types of pain, or neuropathic pain or nociceptive pain. Everything was thrown in the mix, and you cannot conclude
pain.
Because neurobiology is so different. And then but the conclusion is guidelines, everything is contraindicated. Acupuncture, manual therapy, which we know clinically that it's quite effective for certain types of pain, lumbar radicular pain. But anyways, it's you said it beautifully in the beginning, which is kind of meeting the dental area, the dental medicine and osteopath have to come together to work with this particular subject. And it's almost like the science and clinical reasoning have to come together also to as in a lot of conditions and work together. So I think that's the best way to finish with this. Anything else you want to add to this argument?
Well, since you mentioned neurobiology, just to add that, notwithstanding this skeptical colleague of mine that doesn't believe that there is a connection between posture and occlusion, here in Italy we have a wonderful team that is studying connection not between occlusion and posture, but between occlusion and brain and neurological diseases. I mean, Alzheimer, Parkinson, and all these papers were published not on the parish bulletin on the church around the corner, but some of them were published on Lancet.
Oh.
So it is unbelievable how good we could do with we can treat mouth properly, and how bad we can do if we don't understand or we deny all the connection from this area to the rest of our body. And that is not my opinion, that is a fact.
Very good, Stefano. Thank you so much for your time. I'm going to just say good evening in Portuguese. Obrigado por se terem juntado a nós.
Obrigado.
E em breve vamos ter 2 podcasts interessantíssimos, um de cefaleia cervicogénica e outro relacionado com o trauma e doença mental, também todos na perspectiva e abordagem osteopática. E até breve e obrigado.